mentor to both myself, Dr. Bola, and many sleep physicians across the province. And so we're delighted to have her speaking to us today about pediatric hypoventilation. So I'll hand over to you, Dr. Amin. You can start your presentation.
Sure, thanks, Dr. Mehta, for the kind introduction, and thank you very much to the organizers of the conference for the invitation to present today. I think the first thing to say is that it is so absolutely amazing to see such a great turnout for pediatric sleep. This is a field that is so much in need of attracting more people to the field, because especially in the last few decades, we are realizing this really is an underserviced area. So it's really exciting to see such a huge turnout today. Given that I'm giving a Zoom presentation, I'm speaking into a black hole. So please, I'm more than happy for you to unmute yourself and ask a question during the presentation. Please feel free. I want to make sure that you, as the attendees, are getting out of this talk what you need to. All right. So with that, I'll go ahead and get started. So the roadmap for our presentation today is that we're going to talk a little bit about the respiratory system equilibrium and disequilibrium. We'll then talk about some patients who are at risk of hypoventilation. I'll present a couple of clinical cases. We'll talk about the diagnosis of hypoventilation, actually how you make that diagnosis. We'll then review the non-invasive methods to measure carbon dioxide levels, and sort of some of the pros and cons of each of those methods. And then we'll finish off with a very brief review of treatment of hypoventilation. So there's multiple physiologic changes that occur during sleep. And the bottom line is this results in a net increase in the PaCO2 by about 2 to 4 millimeters of mercury. And there's also a drop in the PaO2 of about 2 to 3 millimeters of mercury. So why does this happen? It happens for a myriad of physiological changes. So it happens because of decreased sensitivity of the chemoreceptors. There's decreased pharyngeal dilator activity. There's a drop in our tidal volumes. There's an increase in our breathing rate. There's a fall in our functional residual capacity. There's also a loss of sort of our basal wakefulness drive to breathe. And then, of course, as we all know well, there's relative muscle atonia in REM. So when you look at actually the ventilatory responses to carbon dioxide, they're significantly different than what they are during wakefulness. And the bottom line is that we don't respond as well to CO2 when we're asleep. And secondly, there is progression with sleep stage. So you can see that the slope of this line here, hopefully you can see my mouse, is flattening out as you go from awake to non-REM sleep and then to REM sleep. So the net effect is that there's a decreased ventilatory response to CO2 with sleep stage progression. So in order to really understand, what goes wrong when individuals hypoventilate, it's really important to think about what the normal state is. So in the normal state for you and I, there's a balance between respiratory load on the one hand and central drive and respiratory muscles on the other. And when patients have a decreased central drive, as a result of this, there's decreased activation of the respiratory muscles, and the net effect is that the respiratory load is too high and it just can't be met. And that's one of the causes for hypoventilation. You can also have the scenario where you actually have an increased respiratory load. And so to try and meet that need, there's increased central drive, and it tries to activate these poor respiratory muscles, but they just can't cope. And again, the net effect is hypoventilation. One of the most common patient populations in pediatrics that actually develop hypoventilation are individuals who have a neuromuscular disease. So here the muscles are intrinsically weak, and as a result, they can't meet the inspiratory load. And despite the central drive sort of revving up to activate the muscles, because the muscles are intrinsically weak, they can't keep up with the load. And at-risk states for these individuals is actually sleep and also acute illnesses. So when we think about patients who are at risk of nocturnal hypoventilation, it's really helpful to understand the pathophysiology leading to the hypoventilation when we go to sort of categorize patients who are at risk. And I like to put patients into 3 large buckets. So bucket number 1 are those who have an increase in respiratory load. This is probably the bucket that you're most familiar with. These are the children who have either increased upper airway obstruction, like children with trisomy 21, or those who have lower airway disease. So it can be lower airway obstruction. It can be lower airway respiratory disease like asthma or cystic fibrosis. The second big bucket are those who have a decrease in the performance of their respiratory muscles. So think of anyone who has a neuromuscular condition or somebody who has a kyphoscoliosis, so has a scoliosis, and so the overlap of the respiratory muscles is such that it's just not as effective. So although the muscles themselves aren't weak, because of sort of the overlap of them with a scoliosis, they're functionally not as effective as they otherwise would be. And the third big bucket are those who have a dysfunction of the central drive. So these are children who have either congenital central hypoventilation syndrome or another central hypoventilation syndrome called ROHAD, so rapid onset obesity with hypothalamic dysfunction and autonomic dysfunction. Or individuals who have a Chiari malformation or potentially tumors or syndromes like Prader-Willi. Now, just as a review, the ICSD-3 classifies sleep-related hypoventilation into 6 categories. So the first is obesity hypoventilation syndrome. That's when you have a daytime PaCO2 of more than 45, so you're hypercapnic and also obese, so with a BMI of more than 30. The second is congenital central alveolar hypoventilation syndrome. The third is late onset with hypothalamic dysfunction. The fourth is idiopathic, so we can't actually find an explanation for the hypoventilation. The fifth is sleep-related hypoventilation due to medications or substances such as alcohol or benzodiazepines. And lastly, sleep-related hypoventilation due to an underlying medical disorder. So for example, a patient who has end-stage lung disease from cystic fibrosis, they're going to develop hypoventilation as a result of that. And it's important to be aware of these categories because these are the patients who are going to be presenting to your sleep lab. So now that we've talked about the pathophysiology of hypoventilation as well as its classification, I want to move on now to present a couple of clinical cases to highlight sort of the spectrum of patients that can be coming to the sleep lab who have hypoventilation. But before I do that, let me just pause to see if anybody has any questions. Again, don't be shy. This is your opportunity to ask sort of your burning questions about hypoventilation.
For the kyphosis, hypoventilation is due to alveolar or due to the structure problem?
Sorry, I missed the second part. Is it due to an alveolar issue versus?
Yes, lung versus the body position.
Yeah, so it's a good question. So I think the final common pathway is that typically if you have a straight spine, the respiratory muscles, I think I'll hold them up so you can see my hands. Usually the respiratory muscles will have a nice efficient overlap so that when there's muscle contractions, it's effective and strong. What happens in the setting of kyphoscoliosis is that now they're not really lining up as well. So the muscles themselves have a mechanical disadvantage. And as a result, the overall net function of the respiratory muscles is weak. So it's more of the end result is sort of an alveolar hypoventilation secondary to a mechanical issue.
Thanks.
Okay, so let's start with the case. So this is a 1-month-old baby who has Pierre-Robin sequence and cleft palate. So again, this sort of constellation of glossoptosis, retrognathia, small little jaw with the tongue sort of falling back. This baby had been in hospital since birth. There's been multiple attempts to manage this baby using a nasal trumpet, but again, this just made the baby upset. They have a G-tube because there is significant reflux and feeding difficulties. And initially an overnight oximetry was done, which was quite abnormal. So the baby it was decided then the baby would have a sleep study. So next is a video. I hope the audio works. Please let me know if it doesn't. See. So hopefully the audio was able to work there, that you were able to appreciate that visually, the increased work of breathing and the head bobbing, but as well as the tachypnea and the significant stridor. So this child had very severe obstructive sleep apnea. The apnea-hypopnea index was actually 98 per hour, reminding ourselves that anything more than 2 is abnormal. There were associated severe oxygen desaturations, and there was significant hypoventilation with the CO2 of more than 50 for 72% of the night. And again, criteria for hypoventilation is a CO2 more than 50 for more than 25% of the night. So this next slide is just an overview of the sleep study. So at the top, we have the hypnogram. So just to orient you, for those who are not familiar, the blue is during wakefulness, the red is during REM sleep, and then the black is during non-REM. We have then body position. So this is supine, and everything else the patient slept on their right side the whole night. Then we have oxygen saturations, and you can appreciate these clustered oxygen desaturations. So just to give you a sense of scale, this is sort of the 70% line here. And you can see clustered desaturations that really nicely correlate with REM. So we have REM-related severe oxygen desaturations. Next here, we have transcutaneous carbon dioxide. And just again, for scale, this line here represents 55 millimeters of mercury. So you can see that with the REM-related oxygen desaturations, we also have hypercapnia, so elevated CO2s that correlate really nicely with the drops in O2. And on the bottom here, I've just shown the little ticker tapes for every obstructive event, and you can see the numerous, almost continuous obstructive events happening during REM. So this patient has REM-related severe obstructive sleep apnea with associated hypoventilation. And this patient has this as a result of an increased respiratory load. So they fall in sort of that first bucket. So case number 2, this is a baby who was born full term. The pregnancy was unremarkable, initially had good APGARs of 9 and 9. The cord gases seemed fine. This baby developed cyanosis at 30 minutes of age and was noted to have very shallow respirations, had a very extensive workup, and really nothing came up as being positive. Was initially started on some CPAP and then switched to non-invasive ventilation because the baby was still having apneas despite being on CPAP. It was noted that there were some PVCs on the ECG monitor. The apneas persisted, but again, the clinical workup was negative, and the baby and also the septic workup was negative. So this baby went on to have a sleep study. And again, on this slide is just an overview again of the results. So at the top again is our hypnogram. So red is REM, black here is non-REM. Then down here we have the oxygen saturations, and you can see that this sleep study is quite different from the one that I showed you previously. So in the one I showed you previously, the patient was actually worse during REM, which is what we typically think. In this patient, if you appreciate, the oxygen saturations are much lower during non-REM. So this is non-REM here. This is where the oxygen saturations really seem to bottom out. And same thing for this non-REM period and also for this non-REM period. When we continue further down the screen, we have here our transcutaneous carbon dioxide, and you can see that with these associated drops in oxygen saturations, we're really appreciating a peak in our carbon dioxide levels. And just because the numbers are small, just for scale, this is 60 millimeters of mercury here. So you can see there's sort of a rise in the CO2 that really is associated with what's happening in non-REM. So this is 2 minutes taken, so it's 4 epochs, so 2 minutes taken from the sleep study during non-REM. This is our thermistor, this is our chest, abdomen, and some belts. This is our heart rate, so ranging between 109 to 111. Here's our transcutaneous carbon dioxide. You can see sort of sitting 56 to 57 the whole night. And these are our oxygen saturations that are sort of sitting in the 90s. So this patient has a diagnosis of congenital central hypoventilation syndrome. So I highlight this case because traditionally almost every single sleep disorder is worse during REM sleep compared to non-REM, and as a result, they're worse during the second half of sleep. In congenital central hypoventilation syndrome, the patients are worse during non-REM sleep, and as a result, they're worse in the first half of the night. So if you see a patient who has significant hypercapnia, so their carbon dioxide, and you're appreciating that they have this, it's worse in non-REM compared to REM, that is CCHS until proven otherwise. So believe it or not, this patient has a family history. So, and we'll talk about this on the next slide, but mother also had the same gene mutation, also was using ventilation, as was the son, who ended up needing to go on to have to be invasively ventilated. So with congenital central hypoventilation syndrome, the gene for this was discovered in 2003. So it is a genetic disease. The majority of cases occur spontaneously, but they can be inherited in families because it is autosomal dominant. Essentially, there's a decreased chemoreceptor sensitivity to carbon dioxide. So for you and I, when we have rising carbon dioxide levels, we will increase our respiratory rate and our tidal volumes to be able to match those. But in individuals who have CCHS, they are not able to do that. There's a range of severity, all the way from needing ventilation just at night, all the way to needing ventilation 24 hours a day. And the other fascinating thing about this disease is that there's often multi-system disease associations. So these individuals, there's known associations with tumors, there's known associations with cardiac disease, there's known associations with Hirschsprung's, and also eye problems. So it typically presents at birth with cyanosis or presents with a bruit, like a life-threatening episode. The rest of the workup is sort of is unremarkable. So it really kind of fits with an unexplained need for ventilatory support. And there's also a late onset CCHS phenotype where individuals can present later in life. So it's a really fascinating syndrome. Okay, so this is case number, and just before we go to case 3, so for case number 2, that was a case of hypoventilation due to central causes from the diagnosis of CCHS. So case number 3, this is a 10-year-old boy with Charcot-Marie tooth. This child clinically was complaining about morning headaches. So right when they woke up, they had a headache that then sort of dissipated within 20 minutes. And they do have an oximeter at home, and they were noted to have oxygen desaturations at night. So to further investigate this child went on to have a sleep study done. Here is the overview of the study. So again, blue is wakefulness, red is REM, black is non-REM. So you can see from the oxygen desaturations, there's really deep desaturations. This is sort of 77% right here that are predominantly during REM sleep. And then you can see this sort of significant peaks and rise in CO2 that really relate to sort of these REM-related desaturations. This is again 2 minutes, so 4 epochs from the night during REM sleep. And you can see this patient has a very long, prolonged obstructive event. And then here is the transcutaneous CO2 sitting between 59 and 60, and the oxygen saturations are sitting in the 70s. So this patient had a CO2 that was more than 50 for 97% of the total sleep time, so essentially the entire night, and had a CO2 of more than 55 for 106 minutes. Even the awake baseline CO2 was quite elevated. So this patient was having both daytime and nocturnal hypercapnia. So this third patient had hypoventilation on the basis of weak respiratory muscles. So to go back to this diagram, our first case, the child with the Pierre-Robin syndrome had hypoventilation as a result of increased respiratory load. Our patient with this Charcot-Marie tooth, who had a neuromuscular condition, had hypoventilation because of decreased performance of the respiratory muscles. And then our second case, the child with the CCHS, had hypoventilation on the basis of dysfunction of central drive. So the American Academy of Sleep Medicine categorizes how we should define hypoventilation. So there's pediatric criteria and adult criteria. So one thing to highlight, pediatric criteria can be applicable for anyone sort of up to 18 years of age. And adult criteria can be applied for individuals between 13 to 13 years of age and above. So what that means is that you can apply either pediatric or adult criteria if an individual is between 13 to 18 years of age. And your lab can decide whether you're going to score them and report them according to pediatric criteria or adult criteria. So the pediatric criteria are a CO2 of more than 50 for more than 25% of the night. And the adult criteria, just to review, are a CO2 of more than 55 for more than 10 minutes, or a 10 millimeter increase in PaCO2 from awake to sleep, which is more than 50 millimeters of mercury for 10 minutes. So you're all familiar with those pediatric and adult criteria for hypoventilation. But what I want to highlight is sometimes we have other clues that patients are either at risk for hypoventilation or have hypoventilation. So hypoventilation can actually present with low baseline oxygen saturations. You can have relative hypoventilation because there's blunted respiratory effort, or you could have preservation of the CO2 because the patient is actually breathing so quickly to maintain their CO2. So here, what I'm showing you here is a classic sort of finding of obstructive hypoventilation. So here we have our obstructive event. It's during REM. This is what we're all familiar with. Our oxygen saturations here are 69%, and the black here represents transcutaneous CO2. So always a problem if the CO2 is higher than the oxygen saturations. But this is classic obstructive hypoventilation that we're all familiar with. But what I want to highlight is that for those who do oximetries at home as part of your clinical practice, patients who have low baseline saturations, this can be on the basis of hypoventilation. So when you see this, it's important that you think about getting a blood gas. And then I also want to show this screenshot of a patient who's also at risk. So this patient, and yes, this is really just one full 30-second, one full period, but this patient is breathing so quickly. So this is a child who actually had a neuromuscular disease, and they were breathing, we did a sleep study, and they were breathing between 80 to 100 the entire night. And although their CO2 is 36, this is considered relative hypoventilation because they're having to really stress their respiratory system so much to maintain that CO2. Can you imagine what happens when they have an intercurrent illness? There's just absolutely no reserve. So this patient who's at risk, although their numbers are fine, we did choose to electively initiate non-invasive ventilation to provide some respiratory rest and support and reserve for this patient. So be aware of the patient who's very tachypneic despite having seemingly normal CO2 levels. Okay, so maybe I'll pause there again and ask if there's any questions. Okay, we'll keep going. So why do we measure carbon dioxide during sleep studies? Well, it gives us essential information to understand the patient's physiological status, especially their ventilatory status. It helps us understand and identify these sort of at-risk patients that we discussed. And then for those patients where we're doing ventilation titration studies, it helps to inform the titration. So how can we measure carbon dioxide? We can do blood gases, we can do end-tidal carbon dioxide, and we can do transcutaneous CO2. So I'm going to spend a little bit of time going through some of the technical details of end-tidal CO2 and transcutaneous, just as a refresher. So capnometry and capnography, they're often used interchangeably, but capnometry refers to the partial pressure of carbon dioxide that's detected at the end of exhalation. And this is the end-tidal carbon dioxide because it's the end of a tidal breath, and it's normally between 35 to 45 millimeters of mercury. Capnography refers to actually the waveform. So it demonstrates how much CO2 is present at each phase of the respiratory cycle. And it also measures and displays the respiratory rate. So let's just review the normal CO2 waveform. So here between A, this is where exhalation begins. Here between B and C, this here represents, this is where your alveolar gases are mixing with your dead space gases. Between C and D is your alveolar plateau. And then right here where D is, that's your end tidal CO2. And then beyond that, CO2 falls because this is when you begin inhalation. Okay. So how does capnography work? I think it's important to understand that. So just as a brief review, capnography uses infrared radiation to make measurements. So essentially here, these are on my, you can see my mouse here, hopefully, these are the molecules of CO2. These molecules of CO2 will absorb the infrared radiation. The amount of radiation absorbed has nearly an exponential relationship to the CO2 concentration that's present. So the amount of CO2 that gets absorbed leads to an output based on the amount of CO2 present, based on the amount of infrared radiation absorbed. So similarly, in the picture on the bottom, where you have a lot more CO2 molecules, you're going to have more infrared radiation absorbed, and that's going to translate into a higher CO2 output. So we use side stream technology in the lab. It's measured, via nasal or nasal oral cannula, as in comparison to what's done sort of in an ICU setting, which is through the tracheostomy, through either a tracheostomy tube or through the endotracheal tube. And so here you aspirate a small sample from the exhaled breath through the cannula, tubing next to a sensor located inside the monitor. And it's lightweight and it's not contaminated very easily. So that brings us to our next case. So you're doing a sleep study for a 2-year-old child with a neuromuscular disorder. The end tidal CO2 recording is reading about 5 to 10 millimeters of mercury lower than the transcutaneous CO2 recording all night. Which of the following could be the cause? Is it A, the patient has tachypnea? B, the patient is mouth breathing? C, this child has severe asthma? D, A and B, or E, all of the above? Anybody want to hazard a guess? Okay, so the answer is E, all of the above. So let's go through that. So end tidal CO2, it's important to understand the limitations of this technology. So it's not accurate in the following scenarios. So if a patient is tachypneic, you're not going to get the appropriate CO2 waveform plateau. So you're going to underestimate the CO2. If the patient is mouth breathing, the cannula goes into the nose. They're going to be breathing through their mouth. So you're going to be losing a lot of it. So also it's going to be underestimating. Of course, in the pediatric lab, if they won't even let you get it into the nose, then, of course, tolerance is a big issue. Moisture also plays an issue, and as does the presence of dead space. So anything that increases the amount of dead space with non-communicating airways is going to lead to underestimation of your end tidal CO2. And also patients who have significant asthma with diseases leading to significant gas trapping, their end tidal CO2 is also not going to be accurate. So ideally, if you have both CO2 recordings continuously over the course of the night, the value should be within plus or minus 5 millimeters of mercury. If not, check the computer calibration, check the cannula position in the nose. So make sure the prongs are inside the nose and not actually touching the sides of the nose. Make sure you look for kinks in the tubing, along the tubing, and then check the cannula for excess moisture. And if there is, then replace it. And of course, we touched on this, that if the patient's mouth breathing, then the end tidal CO2 is not going to be accurate. Okay, transcutaneous CO2. So how does this work? So here it measures the skin surface PCO2. It increases the local temperature of the skin at the sensor site, which leads to increased perfusion of the capillaries. So basically, heat will increase the solubility of CO2 in the blood. and you'll increase the metabolic rate of the skin by 4 to 5% for every degree, which results in increased local production of the CO2. In terms of site choice, you probably all know this better than I do because you're the ones applying the probes at night, but in general principle, upper chest for neonates and smaller children. And generally what happens is you put 1 to 2 drops of the contact gel inside of this ring, and then you snap it shut and off you go. So our next case, so you're doing a diagnostic sleep study for a 13-year-old obese girl. You notice that the transcutaneous CO2 is trending 10 millimeters of mercury below the end tidal CO2. Which of the following may be the cause? Is it A, improper sensor placement, B, greasy skin, C, an air bubble, D, A and B, or E, all of the above? So any takers for this question? Okay, so the answer is E, all of the above. So this slide here is just really a grocery list of what are the different things that can increase transcutaneous CO2 levels and what are the things that can decrease it. So for those of you who do transcutaneous CO2 monitoring, you know that it is incredibly challenging. Really the expertise of the sleep tech is quite admirable. You know, calibration, appropriate application, and ensuring that the signals aren't drifting. And if you're concerned about the accuracy, then recalibrating, then reciting, and sort of chasing the values over the course of the night. Because generally with transcutaneous CO2, what can go wrong, unfortunately, does go wrong at some point during the night. So it's important to sort of have a good sense of what are the different things that can lead to a decreased transcutaneous CO2 over the night, so you can troubleshoot those. And similarly, making sure that you also are aware that there are things that can falsely increase the CO2, especially if the patient's lying on it or it's not calibrated properly. Okay, so we talked about that already. So just bird's eye view of end tidal CO2 versus transcutaneous. So the advantage of end tidal CO2 is that it gives you breath by breath analysis. It's relatively easy to use and of course non-invasive. But the disadvantages are that it can't be used during a PAP titration. It'll underestimate the CO2 in patients who are tachypneic or if they have increased dead space. Excess moisture is also an issue. There can be a lag time between sort of actual and reported values. And many children, as we know, for those of you who do pediatric sleep, don't tolerate the nasal cannula. In contrast, for transcutaneous CO2, this can be used during PAP titrations. It's also non-invasive, but the disadvantages really relate to all of the technical issues that can potentially go wrong. So we're on the home stretch here. I'm just going to touch on treatment of hypoventilation, but before I move on, just wanted to again give everybody an opportunity if there's any questions that people want to ask.
Is it possible, because this is since 2003, is it possible of SIDS happening before that? Explain why this syndrome?
Yeah, it's an excellent point. Yes, absolutely. I think that definitely, and even after 2003, I think that you know, it took a while to become familiar with this syndrome, and that potentially is why some children may have died with the label SIDS, and it may have actually been this. It's a great comment. Thank you. Anybody else?
For Merkel-Cherry, is basically the disease is peripheral polyneuropathy. Why they have respiratory issues?
For Charcot-Marie tooth?
Yes.
Yeah, it is peripheral, but I think it comes back again to respiratory muscle mechanics.
Okay.
Yeah. And especially in REM, they just, because of the relative muscle atony, they manage themselves most of the time. And especially during REM, they just can't maintain themselves because they're already using accessory muscles. They just lose that in REM. That's why they just really plummet during REM. Okay, so we'll We'll touch just briefly on treatment of hypoventilation. So really the founding principles are, number one, to try to treat the underlying cause. So if there's a surgical intervention, then to do that. So for example, if a patient has a Chiari malformation, which is leading to severe obstructive or central apneas with associated hypoventilation, then it would be to do a posterior fossa decompression to correct the underlying cause. For patients who have obesity hypoventilation or obesity related syndromes leading to hypoventilation, then of course, as an adjunctive therapy, making sure they're enrolled in a healthy living program for weight management. But despite that, still a large proportion of patients still need to go on to medical management through non-invasive ventilation, through a mask, as you can see in this picture of this little girl, or invasive ventilation, which is through tracheostomy. But I thought discussion of invasive ventilation is probably just a bit beyond the scope of the patients that are commonly being seen. So I want to just focus on non-invasive ventilation. And I think the first thing that I wanted to highlight is really, although we've become much better at non-invasive ventilation in children, in the last decade, there still are some children who aren't good candidates for non-invasive ventilation, and it's important to be aware of these. So relative contraindications. So if patients have significantly uncontrolled bulbar dysfunction, which leads to them having increased oral secretions, NIV is a contraindication because the use of NIV can potentially worsen their microaspiration of their upper airway secretions. If you already have significant uncontrolled GERD, then using positive pressure is potentially dangerous because even though you want the air to be going into the airway, nevertheless, some of it's going to cause gastric insufflation, which of course may worsen gastroesophageal reflux. So it's really important for the GERD to be managed prior. In addition, it takes a lot of parental support at home to get somebody successfully onto non-invasive ventilation. Sometimes that's just not feasible given the home situation. We typically aren't putting children on non-invasive ventilation if they're dependent on support for more than 16 hours a day. If that's the case, then they would be transitioned to invasive ventilation. It's important to think about the timing for initiation. So often, if they've had recent, neurosurgical intervention or craniofacial intervention, the surgeons are not going to want you to start therapy until, variable periods of time up to 6 weeks after the procedure. And then, of course, tolerance and adherence really is the Achilles heel of PAP therapy in general, and also of ventilation. Just like when you think about CPAP, non-invasive ventilation is the same. It's all about the mask and the interface, and that's where success begins. There's so many different options available for children, and we don't have as many options available as adults, but we have more options now than we ever have before. So we have nasal masks, we have nasal pillows, we have oral nasal masks, and we have total full face masks. And the kinds of considerations that we think about when fitting children depend on sort of their age and their weight, what their anatomy is like, comfort, tolerance, ability or need to remove if unattended. So if there's a patient that we really need to start on non-invasive ventilation, they have some reflux, but it's not perfectly controlled, we're of course going to prefer a nasal mask as opposed to an oral nasal mask, just in the event that there is reflux aspiration. And some of the common issues that we face as a result of using non-invasive ventilation, the masks, is that there can be significant skin breakdown. Over time, especially in the younger children, they can develop mid-face hypoplasia. So that's just flattening of the facial bones because we're using masks with significant pressure that are secured with a headgear at a time where children have developing facial bones. There can be significant nasal obstruction, which of course really affects the comfort of this. Can you imagine if you have increased nasal resistance already because of large turbinates or edema or swelling, and now you're putting the mask on with all of this positive forced air? It's very, very uncomfortable. So we have to make sure that we're thinking about treating the nasal obstruction in parallel. And for patients who are mouth breathers, A nasal mask is unlikely to be successful. You can always try it because sometimes once you do have the sensation of air through the upper airway does lead to mouth closure, but often it's not successful and you may need to consider then going to use a chin strap to keep the chin closed or going to an oral nasal mask. When we think about device selection for ventilation, our life is a lot easier because with the Ontario ventilator equipment pool in Ontario, we only have one choice of machine for invasive ventilation. And we only have a handful of choices for non-invasive ventilation, but still it's important that we think about when we choose devices based on triggering, alarms, modes, and also what age the device is licensed down to, because for young infants who are very weak, they're going to have difficulty triggering a machine that's actually, developed for individuals who are 30 kilos and more. And on this last slide here, it's a lot of small writing, but it's more just as a reference guide, as a tool in terms of sort of an approach to some of the general settings and the things to be thinking about. So just in terms of choosing different modes, in terms of our target volumes, a good sort of rough rule of thumb is about 8 cc's per kilo. Here are just some ideas of sort of some of our starting inspiratory times that we recommend. So for the infant, sort of 0.7 to 0.9. For children, we like to try and get at least 1 and above. Rise time is going to be different on different devices, as you know, and the optimal rise time is really determined based on bedside titration. Triggering is important, especially for the pediatric patient, especially thinking about patients who have a difficult time triggering. So you want to make it very easy for them to trigger. So choosing settings like high or very high, but you also don't want to make it too easy for them to trigger because then they're going to start to auto cycle. And then for the cycle time, again, you want to make sure that you're balancing the ease to come to cycle from their IPAP to their EPAP. If they have a significant leak, it may lead to premature cycling, so you want to help to manage for that. And then thinking about intelligent volume assured pressure support, or AVAPs, for patients that you think will benefit from sort of a mixed ventilation mode. So in particular, in our practice, we really use sort of these hybrid modes for patients who have obesity hypoventilation syndrome, congenital central hypoventilation syndromes, and also neuromuscular diseases. So in summary, remember, the 3 mechanisms of hypoventilation and the patients that are at risk of hypoventilation. We've talked about how non-invasive carbon dioxide monitoring is an important tool and adjunct for sleep studies. I've highlighted sort of the advantages and disadvantages of non-invasive measurements for CO2. And it's important to be aware of the technical and patient-related limitations of each. It's important both if you're the one doing the sleep study, but also for the clinicians who are interpreting the data. And then lastly, NIV is a great therapy, but it isn't right for everybody. I think that's the first thing. And then secondly, a lot of thought has to go into the choice of the interface, and then thinking about the right device and the right setting. So all of those things help to increase your chance of success. And with that, I will stop and ask again if there's any questions.
Thank you for that great presentation. I had a question for you if no one else has any, and I'll look at the chat as well if anyone puts a question in there. I'm just curious your thoughts, on the definition of hypoventilation, especially in children. You showed us the ICSD-3 criteria. We talked about the sleep study criteria. I'm just wondering your thoughts on how, solidly you stick to some of these numbers. I know there's guidelines that have come out for other patient populations that kind of specify a little bit different cutoffs. So what are your thoughts on, where you initiate treatment, or what do you think of those cutoffs?
Yeah, that's a great question. So the guidelines that Dr. Abet is alluding to are their guidelines were published in Lancet Neurology specifically for patients who have Duchenne muscular dystrophy. So there's a lot of conversation, like sort of an emerging movement of clinicians who look after individuals with neuromuscular disease who really feel that the ASM criteria don't do justice to patients who have a neuromuscular disease. For example, these DMD criteria, so just to remind ourselves that for the pediatric criteria of hypoventilation, you're looking for a CO2 of more than 50 for more than 25% of the sleep time. In these Duchenne, specific criteria, the writers there argue for starting ventilation if your CO2 is more than 50 for only 2% of the sleep time, or if your SATs are less than 88% for 5 minutes. So they're much less rigid criteria. And the argument there is that, the whole point of managing neuromuscular patients is to ensure early intervention to prevent deterioration and admissions to hospital, and feeling that the ASM criteria are too stringent, so it really delays the prescription of ventilation. We will, for the neuromuscular patients as a whole, we generally practice in accordance to the sort of Lancet neurology guidelines. So we are quite proactive with getting patients onto therapy. Really, because especially for the Duchenne population, it takes them a long time to become adherent. So the sooner the better. The other piece along that is really this concept of obstructive hypopneas versus central hypopneas. So for the ASM guidelines, anything that has paradox, if you have an obstructive hypopnea, you can't, even if you think it's sort of central in nature, if there's the presence of paradox, you have to call it obstructive, which of course in an individual who has neuromuscular disease, paradox may be on the basis of their neuromuscular dysfunction as opposed to just the individual event. So sometimes we sort of break the ASM rules a little bit and call them non-obstructive hypopneas, or just use a general term of hypopneas. But again, thinking beyond just the criteria and beyond just the AHI. And that's why I wanted to raise the points about looking at respiratory rate, respiratory effort, as well as oxygen saturations, because these are all ancillary pieces of information that you can use to really understand the patient's physiology and not just rely on just the CO2 numbers.
Thank you. Are there any other questions from the audience?
Excuse me, I got a question here. Is that a hypoventilation syndromes, as Dr. Amin talked about and categorized in 3 different groups, that much common that we ordered CO2 monitoring for every child? Or just CO2 monitoring is another way of measuring the respiratory rate, like nasal, cannula, and thermistor?
Thank you for the question. Just to make sure I understood the question, was your question that you were asking if we do CO2 for every pediatric sleep study?
Yeah. I want to know, is it that much common, this kind of hypoventilation, that we order CO2 monitoring for every patient, every child patient?
Yeah, it's a very good question, and I think that probably our lab at Sick Kids is, as you can imagine, a very skewed population, because I think we probably study less than 10% of healthy children. So for the patient population we're seeing, it is relatively common, unfortunately. I think adult medicine is quite different, and I know that CO2 is not mandatory for adult sleep studies, but one form of CO2 monitoring is mandatory for pediatric studies. So it is. So we do both. We do end-tidal and transcutaneous for every sleep study at Sick Kids. But I know that is a departure from what is done in the community, largely because transcutaneous CO2 is incredibly expensive, and it also is different than adults, where rarely CO2 is measured as a standard in adult sleep studies.
Thank you.
On that note, I was going to ask the audience if anyone wants to contribute of their experience with CO2 in their settings, in their labs, for those that might be seeing kids. Do we have any experiences in the community outside of Sick Kids with CO2 monitoring?
Yeah, hi, it's Sunny here. Yeah, I was, in terms of like the comment about how common it is. In the community setting, I don't feel that it's particularly common. We do it as a matter of sort of routine. And what I do think we see most commonly, and Kevin, you can let me know if you agree, is obstructive hypoventilation. I feel like that's relatively commonly seen. So I do think there's a clear benefit in doing it routinely. And then we have had a few unusual cases of concerns, you know, is this late onset CCHS or ROHAD or something like this? So it's definitely useful to have the resource available. And the blubbering is not me, that's my baby.
Thanks, Sunny.
I agree, and there have been a few instances where, you know, we pick up maybe some fewer formal obstructive events, but the CO2 actually is elevated or quite high. So there's been some interesting discussions we've had whether, you know, CO2 by itself might be in the right patient, in the right clinical context, a surrogate measure for some degree of severity of the obstruction. You know, if the child may not be kind of formally showing obstructive events, and we look at the raw data to look at, you know, some flow limitation, you know, maybe some more subtle features. And there have been a few kids that, you know, the CO2 is more of the prominent finding than the formal obstructive event. So it has been useful in some kids when we're evaluating them, even for obstructive sleep apnea.
Yeah, and it's also helpful. So the other kind of, you know, we have a large patient population referred for snoring and symptoms of OSA. We also have a smaller patient population who's referred for excessive daytime sleepiness. And although typically in children, when they're presenting, you know, daytime sleepiness is not usually a feature, unlike in adults of obstructive sleep apnea. Most children actually become quite hyperactive, but it is seen in some of the teenagers. I think we often have excessive daytime sleepiness as a presenting feature, and really ruling out hypoventilation is essential before moving forward and going down the path of sort of narcolepsy or other excessive daytime sleepiness symptoms and diagnoses.
Any other questions? I'm going to start switching over to my presentation, but feel free to ask any other questions in the last few minutes.
Sorry, one last comment about the utility of having the end tidal. It also helps with these kids with obstructive hypoventilation, because then we know that we can initiate PAP therapy in the community, but they do need further care, and that's helpful to know that they might need non-invasive to titrate appropriately, and be sure that the hyperventilation we're seeing is actually just obstructive. So yeah, that's just the only other context in which I've come across the benefits clinically.
No, it's a great point. Okay, well, thank you very much for the opportunity to present today. Nice to meet you all. Thank you for the great questions and discussion.